All for joining. Thank you all for joining tonight. We're very happy to launch our 2025 virtual series that's titled Tell Me More: Modern Approaches to Psychotherapy. And it's my sincere honor to introduce Dr. Elizabeth Maroney for this first session that's on treatment of obsessive compulsive and related disorders in youth, exposure and response prevention, or ERP, and habit reversal training, or HRT. Just a little bit background on Dr. Maroney. So I have the fortune to get to work with her at Lurie Children's Hospital in the Children's OCD Anxiety Spectrum and Tic Disorders program, also referred to as COAST. In terms of some of her background, she has an undergrad degree from University of North Carolina at Chapel Hill, and she completed a 2-year post-bac fellowship at NIMH, which is where she started her clinical research in children and families. She worked on multi-site studies, looking at anxiety, and then completed her graduate training in clinical psychology at UCLA, and did several externships across settings in LA, in addition to training at the ADHD and Development Lab, and then did a pre-doctoral internship at Stanford Children's Hospital and Children's Health Council in the Bay Area. And then her 2-year postdoc fellowship focused on pediatric OCD, anxiety, and tic disorders at Weill Cornell Medical Center and New York Presbyterian Hospital. And now at Lurie, through the COAST program, she's treating kids with OCD, complex anxiety, tic disorders, trichotillomania, kind of all the OCD related disorders. And a lot of the approaches that she uses relies heavily on CBT, including exposure response prevention, as well as the SPACE protocol, which is supportive parenting and anxious childhood emotions. And then she also does intensive group work for complex and anxiety and OCD presentations, along with individual therapy. And she's working to develop a clinical research program at Northwestern, and she's presented at national and international conferences and has published in multiple peer-reviewed journals. Just quite an impressive resume, and I'm so touched to be able to work with you. But we're really excited to have you here, and I'll let you take it away.
Thank you. That was so kind, and I'm so happy to be here. I am going to share. Hopefully this will work. What are you seeing?
We're seeing PowerPoint. It's not on presenter mode yet. There you go.
Feel like okay? Great. Okay. So yeah, so happy to be here. I'm going to be talking about evidence-based treatments for OCD and sort of related problems. I will kind of hone in most on exposure and response prevention, or ERP. And we actually got tons of questions about that to start the night. So thanks so much for your interest and for being here on a snowy Thursday. I do not have any disclosures. So my goals are to just kind of provide a little bit of a refresher on OCD. I know there were some questions about assessment and, sort of how someone might be a good fit for ERP, theoretically things that everyone's probably had in their training, but I think it'll be helpful to do a little bit of a deeper dive into, what this therapy really looks like when you're in the weeds with a patient, both to kind of inform your recommendations and so that you can hopefully start incorporating these principles into your work, as early on as possible. I will talk a little bit about habit reversal training, sort of under the umbrella of treating body-focused repetitive behaviors, so trichotillomania and excoriation disorder, if we have time at the end. I also do a decent amount of work treating tics and Tourette's, and habit reversal training is a really big part of that, but we probably need another whole presentation on that. So if there are any questions about, how the treatments differ and sort of how to treat Tourette's and tic disorders, I'm happy to talk about that in the Q&A as well. And as Dr. Singh mentioned, I work at Lurie Children, so I am focused on children and adolescents. I'm going to talk about treatment in that population, but I'm going to try to provide some considerations for translating these treatments in adult populations. The spoiler alert is that it doesn't differ all that much. There are a couple of considerations to think about, but the core principles really remain the same no matter how old the person you're treating is. So I always like to open ERP lectures with this slide, which is taken from an Atlantic article, I believe in 2016. And it's discussing exposure and response prevention as the only cure for OCD. Very, dramatic, alarmist title here, but saying the only cure for OCD is expensive, elusive, and scary. And it dives into, it's a really interesting article about different patients that have gone through ERP and the idea that this treatment is all about facing our fears, which is really important. I don't think the general public, necessarily knows that. But it's also a treatment that's really hard to find. There are, not that many folks that are trained to do this specialized work. And it can be really, really hard to find insurance covered care and Medicaid covered care. So I think, just something to highlight here. And the more we can kind of get the word out about what these principles are and how to potentially start incorporating them at different levels of care, I think is really important. And one of the things we're doing at Lurie with our new program is really trying to get that care out there to kids who, may not have coverage elsewhere. So super briefly, just epidemiology of OCD. We often see sort of two peaks of onset for obsessive compulsive disorder. The first being in pre-adolescent kids. So those are the referrals that I get, often onsetting between ages 8 and 12. And then we usually see kind of another wave of onset in early adulthood when, lots of mental disorders tend to onset post high school as adults are kind of living on their own and dealing with the stressors of adult life. Lifetime prevalence is about 1% to 2%. That might be slightly underestimated since COVID. We know that rates have kind of risen with OCD and sort of other mental disorders as well, particularly in kids. There were certainly patients who were experiencing, OCD symptoms around contamination that were really exacerbated in COVID, but we also saw a lot of new onset symptoms not necessarily related to the disease itself or COVID itself. So I want to spend a little bit of time talking about what OCD is and isn't. Again, hopefully this will be a review refresher for most folks, but I think it's really important when we're thinking about ERP that we have a good understanding of what this disorder is. And it's a really interesting one. We've got these different components. So obviously the O is for obsessions, the C is for compulsions, and the D is for disorder. And all three of those components are really important. So to start with obsessions, this is sort of the cognitive piece. These are thoughts, worries, fears. It could be pictures that come into a person's mind over and over and over again, and they're very distressing, very anxiety provoking. I think obsessions is often used in a positive way, or, we might have families saying, oh, so-and-so is obsessed with this or this or this. I once had a child patient ask me if there were good obsessions because he loved fishing so much. In the context of OCD, we are talking about very distressing ideas and thoughts, and they're repetitive. They come in over and over and over again. I'll say this a whole bunch of times, but these really do look different for each person. And OCD has a tendency to sort of latch on to what a person is most horrified by or disgusted by. And I think that's one consideration when we think about children versus adults with OCD. We're often thinking about sort of core ideas or beliefs that the symptoms may kind of latch onto and take the form of. And those might look different in childhood versus adulthood. We might see different themes for OCD in adults. For example, adults are more focused maybe on relationships, romantic relationships, and maybe doubts about partnerships. And we might see that less in an 11-year-old. There's a note here that sometimes the obsession is simply around, I'm not going to be able to handle this. And this is important. This is the idea that, the same theme might be triggered in one patient as another. So contamination, for example, But the outcome of the obsession, if we really work through what the fear is, might be totally different. So, for one patient, it might be I'm really worried about getting sick myself and maybe dying or something terrible happening. For another, it might be I'm really sick about, or I'm really upset about getting sick and passing it on to someone else, like an elderly person. And for some, it's just I can't handle that feeling of the feeling of being contaminated or icky or germy. So it really, even with the same sort of idea or theme, the fears might be really different. Again, this can take on so many different forms, but some common examples we see are around germs or contamination, bodily sensations, things in the bathroom, things that come out of our bodies, intrusive thoughts, though I'll touch on that in the next slide. The presence of intrusive thoughts does not necessarily mean someone has OCD. Just right urges, or sometimes very specific worries about objects, health conditions. I once had a patient who was very concerned about lead paint in the walls, and would do significant research and had significant compulsions to avoid lead paint. Vomiting or specific health conditions sometimes comes up, so could be very specific worries as well. I want to touch on intrusive thoughts because I think there's a couple of sort of misconceptions about them. Mm, the first being that some people refer to all obsessions as intrusive thoughts. And I really reserve that term for thoughts that feel very ego dystonic. So, very against someone's identity, their desires, their beliefs, thoughts that really truly feel alien to them. While other obsessions may be, quite distressing, they're not always inconsistent with a person's identity. So, not wanting to get a grandparent sick and worrying about that isn't necessarily intrusive in the same way of, ooh, I'm standing in front of the train, at the train station, and I'm thinking about throwing myself in front of that train. I really don't want to do that. So it's really kind of anti the other thoughts in someone's brain or what they might want in the moment. The experience of having intrusive thoughts is actually very common. So there have been some studies in just like college students or non-clinical samples, and we usually find upwards of 80-90% of people report, yeah, I've had that experience before. I've certainly had that experience at a train station or a stadium and, thinking about doing something that I really don't want to do to hurt myself. But what makes those intrusive thoughts into obsessions and kind of in the context of OCD is really the interpretation and kind of response to these thoughts. And that's what represents the actual obsession. So the idea of, oh, I've had this thought, that must mean something about me. That must mean that I want this to happen. That must mean that I am a pedophile because I've had this thought about, hurting a child or being inappropriate with a child. And so folks who develop OCD who have those intrusive thoughts tend to, believe really strongly that, oh, this is reality. And they also tend to give their thoughts a lot of attention. They get very sticky. Um, and the thoughts then take on, a lot of power, and it becomes really hard to get out of that cycle. So just the presence of intrusive thoughts does not necessarily mean OCD. Um, Compulsions on the other side of the coin are the behaviors. So the actions that someone takes or sometimes does not take, because this could look like really significant avoidance. And that's meant to really quiet or alleviate some of the distress from the obsessions. Sometimes compulsions are very obvious to the naked eye. I've had kids who, are doing things in session. They're walking through the doorway back and forth. They're asking a parent to say a very specific phrase over and over again. They're asking me to engage in certain things, and those are much easier to spot. But we also have compulsions that happen, internally. Lots of mental compulsions. That could be I had a patient who counted the number of words in the sentences that I was saying, and she had to sort of organize the words in a certain way. Maybe it's repeating a certain phrase internally so that things will be okay. Not a coping thought, a very specific phrase that kind of represents more of a compulsion. And then avoidance is a really big one to think about with intrusive thoughts. So in some of the examples I gave, maybe someone's having intrusive thoughts about hurting themselves at the train station and they start to avoid taking the train. Or someone having thoughts about stabbing a family member starts to avoid sharp objects or starts to avoid that family member. So those are often the compulsions with intrusive thoughts. Again, this could take on almost any form, but I think some of the common examples we see a lot are excessive or ritualized hand washing, doing laundry quite a bit, needing to even buy like new clothing if things really aren't feeling clean or sanitized, certain specific rituals before someone eats or before they go to sleep. I'm a huge fan of bedtime routines. This is a little bit different. Maybe avoiding a specific number if numbers there are certain numbers that represent bad luck for someone, or doing things in certain intervals to have good luck. um Mental compulsions, maybe that means going back through someone's day or someone's interaction with someone to comb through and see if they said anything offensive or racist or sexist. Ritualized prayer. And then I think the last one kind of speaks to this idea that OCD can really latch on to anything in someone's environment. I've really seen a lot more in the last couple of years, with teens and their phones, and seeing a lot of compulsive behaviors around, for example, teens will close out of their apps. A lot of people do that at the end of the night so that their phone's not running extra functions or on their battery. And I've had some teens who refuse to close out of certain apps because something bad might happen as soon as I close out of that app. So it's been 3 years of that app running. Or another kid who had a streak going on an app where you got rewarded, you got a badge if you did the app every day. He was learning a language, and it had been 723 days of doing this streak, and if I break that streak, something terrible will happen. So just interesting how these things can really take on any sort of form. And then this piece I think is really important for anything we're thinking about. I think people tend to kind of think about OCD as a binary, or a category, like we do with lots of different psychiatric conditions. And we probably all know people who have some symptoms of checking locks a little bit excessively or washing hands and really not wanting to get sick. Sometimes contextually that might make more sense than in others. And so there's different ways that I think we can think about when this really becomes a disorder. When do we have clinically significant distress and impairment? The DSM provides time as kind of the biggest suggestion. They want to see at least an hour of these thoughts being on the brain or engaging in compulsions. But I think all of these are important to think about. OCD symptoms can cause quite a big impact on families, particularly with children. They're often asking for participation in rituals or for parents or siblings to do certain things for them as a result of the OCD. We call that accommodation. And that can start to get really significant and really impact families. We sometimes see financial implications if kids are asking for parents to buy, lots and lots of toilet paper for rituals, or special foods, or the plumbing starts to get messed up. That can cause a lot of conflict and um, issues with family functioning. School attendance and functioning certainly can come up, or work. If we're needing to do a 3-hour ritual before getting to work in the morning or before getting out the door in the morning, is someone waking up at 5 in order to do that ritual, or are they just late every day? So it certainly just starts to impact lots of different things. And then sometimes we do see physical health impacts if the symptoms are really significant and the patient has very little insight into what the compulsions are doing. I recently had a kid who was drinking hand sanitizer for, contamination concerns. Obviously, the impact of that is going to be much worse than this feeling of feeling contaminated. So sometimes we see, avoidance of certain foods or hand washing to the extent of, lesions and skin conditions, and it really can start to impact someone's physical health too. Just briefly, here's the DSM criteria. The thing I wanted to highlight is insight here. I still consider OCD an anxiety disorder. I think lots of OCD therapists do, but no other anxiety disorder has that insight specifier, and I think that's important to think about. What we're talking about here is sometimes beliefs or connections between thoughts and behaviors that don't make sense, that aren't logical. And so, someone's degree of being able to say, I know that when I knock 3 times on this desk, it's not actually going to prevent my mom from getting into a car accident when she leaves. We might have a little bit better insight there than someone who truly, truly believes that some of these things are likely to happen, or that their compulsion is what is preventing these things from happening. So this is sort of my rough treatment sequence when I'm diving into ERP with a patient or family. I think this is largely supported by the treatment manuals, I would say, but I sometimes will add in like different adjacent skills if it seems like a kid is really needing something additional. An assessment's really important at the beginning. Talked a little bit about what that looks like already. The gold standard assessment tool that we are still kind of using is the SciBox or the Y-Box. And I kind of have a love-hate relationship with this measure. I think it does a really nice job of helping identify common obsessions and common compulsions. There's sort of a checklist of both. And then there's some questions about severity and how much these symptoms are getting in the way. It's quite time consuming. Probably takes an hour if you do it well. And I prefer to do this in an interview format versus handing it to a patient. Um, I think you get really good information about treatment targets and making sure you're on the same page with the patient about what is OCD, what we want to work on. And I think it can be normalizing and validating sometimes to have prompts and some things to suggest that patients might not have thought were OCD or might have done in the past and they totally forgot about, that might really support the diagnosis. But I typically like to kind of confirm the diagnosis through less structured means and then do this in a first or second treatment session, again, so we can kind of zero in on the specific symptoms for exposures. This is just a case example of a kid I worked with a couple years ago, just specifically her compulsions part of the checklist from the SciBox. And I just wanted to highlight that we often see a whole bunch of different domains sort of being highlighted on that measure. It's sort of rare that we might only see symptoms in one area. It certainly happens, but you can kind of see that they're sort of across the map a little bit different here. And I think I've touched on this already, but just keep in mind that everyone with OCD looks very different. You might have, 2 patients with similar demographic backgrounds, even similar themes of OCD, and their exposures could look really different, or their fears could look really different, their compulsions could look really different. I've touched on this a little bit already, but I think when we're thinking about youth versus adult OCD populations, one thing to consider is I think with young kids, sometimes we don't have the developmental capacity to really describe or verbalize obsessions. So we may have full-fledged OCD. I actually have a 4-year-old right now with full-fledged OCD and is really not able to verbalize, what the fears are, what would happen if he didn't do these routines. And so we might hear, oh, I just would feel scared, or I wouldn't feel good in my body, or I just have to do it, versus an adult who's hopefully able to give us a little bit more information about that. Adult themes may differ, like I was mentioning. I think, again, OCD kind of latches on to our fears, our beliefs, what's going on in our life at the time. And so, there might be adult themes that just differ based on that developmental stage. The role of, parents and families in these requests for accommodation within OCD versus maybe, an adult who's living alone or maybe living with a spouse, or even their own children, that might look different in terms of who's involved in the disorder and the treatment as well. Treatment motivation, probably not specific to OCD, but we often obviously have, parents and families who feel very impacted by OCD bringing kids in for treatment. And it may be hard to get kids motivated for individual exposures when that's a really hard treatment, versus an adult who might present on their own and theoretically be a little bit more motivated. And then impairment might look really different, again, just based on kind of our developmental stage and someone's environment. So if we have, a kid and an adult, both with fears about being a pedophile, maybe a teenager, um, an adult may have made certain career or life choices about not having children or about not working in a school setting, as part of their compulsions to kind of avoid being in those settings. Whereas a teenager might have a harder time avoiding being around young children. Okay. I'll kind of breeze through this since I've already talked about it a little bit, but I think about, sort of establishing this OCD diagnosis and then using some of these more specialized measures to really get at the symptom domains and sort of make some targets for treatment. And then, we also want to obviously understand comorbidities and whether OCD is primary here, when we're thinking about sort of motivation for and recommendation for ERP. I really like this model. This is a mentor of mine always uses this, and it's taken from DBT, dialectical behavior therapy, um, and this would be sort of a session model. So in session, you would need to address any life interfering behaviors that have occurred since the last session first. Then any treatment interfering behaviors. Was the patient late? Are they sort of burning the therapist out in some way? Before getting to the quality of life interfering behaviors that are usually what bring people into treatment and what they want to talk about. And I think this is interesting to think about when we're kind of treatment sequencing as well. I think I get a lot of referrals for kids who probably would benefit from ERP, who have significant enough OCD symptoms to need ERP. But that doesn't always mean it's the best recommendation for them at that time. We often see suicidal ideation or self-harm secondary to OCD, and they may need treatment for that first. Kids that have, comorbid ODD and might need some parent management training or really poor distress tolerance, where it feels like, man, I don't think these exposures are going to go super well, because this kid is really emotionally dysregulated when experiencing distress. So we may recommend a different type of therapy first, or we may need to start with other skills before we really dive into the exposures, because they're really distressing and hard. And we want to make sure, that we're going to be somewhat successful and not sending someone into a different symptom domain with those exposures. Psychoeducation, super important. I usually try to do this with the patient and the family if I'm working with a kid or a teen. We talk about OCD in the same way that I kind of presented to you. We talk about anxiety as the body's alarm system. We really hone in on the OCD cycle, which I'll present in a second, and describe what this treatment is going to be. This. So this is the OCD cycle, really, really core to this treatment. And basically the idea that here's what obsessions are. What do those look like for you? And how do they make you feel? And, usually kids are able to say, I feel anxious, I feel really upset. Sometimes I feel disgusted or frustrated. And we really kind of use that verbiage that this is a false alarm, right? Your brain is making you think that you are not safe or okay in this situation, and you are. They're driven to do a compulsion or some sort of behavior to make that anxiety go down. And they do experience some relief after they've done that compulsion. And even little kids are usually able to say, but that relief is just temporary. The obsession comes back. I want to do the compulsion again. I really get stuck in this cycle. It even starts to generalize to new situations or get bigger. And so we, again, just get kind of stuck in this cycle. And so ERP is all about kind of breaking that cycle and helping people be in situations where they can understand that they can resist or not have to do the compulsions. This is basically the cycle in a different way. I usually always include this graph as part of my psychoed, but basically highlighting to folks that if they are able to make the choice to resist a compulsion and stay in a situation, even though it's not going to be as immediate or as quick or as easy as doing the compulsion, eventually their anxiety does go down, at least from that heightened sort of peak state. And we hope that with practice, it's going to get easier, both that the initial anxiety when that obsession pops into someone's head is going to go down, and that it won't take quite as long for us to hopefully get back to baseline. A lot of work sort of to prepare for solid exposure work is making sure we really understand the symptoms well. I think there are lots of excellent providers that really understand these principles at a high level, and then when we start to dive into making an exposure hierarchy, which I often describe as like this is the art combined with the science. We really need to dig deeper and get even more detailed with what the symptoms are, what the feared outcomes are, and ways that we can really iterate different exposures. So we're going to start building an exposure list and a hierarchy based on the patient's symptoms. This is an example of a teenager that had fears about being a pedophile. And we're also going to introduce a distress scale that we can use to help patients anticipate or who are going to rate examples of exposures and give us a sense of how hard something feels like it would be now. And then we're also going to be checking in during the exposure process to see how someone's doing, and afterwards, after they finish it, how they're doing as well. This is a really interesting patient who had, this is not uncommon, an experience in childhood that she felt like had really set off all of these OCD symptoms. It was basically a misinterpretation of a very normal explorative experience with a cousin. And she felt that she had violated the cousin and really done something inappropriate as a 7-year-old. And so developed all of these beliefs and fears around being a pedophile. And she associated there was certainly a magical quality to her obsessions, but associated certain colors with being more childish than others. So she had sort of like safe and not safe colors, and wouldn't use like a shampoo bottle that was orange because it felt more childish. So we really started with some, kind of baseline exposures around things like that, and worked all the way up to, being actually around young children. And then we get to the actual exposure part. And when we're thinking about, what is a good target for an exposure, we think about situations that feel scary for OCD reasons, or situations that have been avoided. Again, maybe that's being around a family member. Maybe that's going to a certain place where someone feels like they had a bad experience. Maybe it's eating a certain food that made them sick in the past. It could be about tolerating the reduction of family accommodation. So, if a kid is asking for reassurance 20 times a day, and we've set a limit of you get three asks for reassurance, and your parents are going to answer. The exposure is about being able to tolerate that. We want to think about targeting the compulsions as almost an exposure in themselves. So the response prevention part is super, super, super important in breaking that cycle. And sometimes when we see someone coming in to treatment, these symptoms are pretty long standing. The compulsions might have been around for a really long time, and it's simply too much to ask a patient to completely resist a compulsion. So we may think about ways that we can change the compulsion, limit or shorten it, maybe even have someone delay. So, for example, touching something dirty and then tolerating, sort of resisting the compulsion for a set amount of time to get that practice before they're able to wash their hands. So we may need to kind of break things down a little bit more. It may just be too much to ask or too hard to have them completely resist. Intrusive thoughts is often about avoidance and approaching those situations that someone's been avoiding, but it's also about the thoughts themselves, because the obsession is often, because I've had this thought, it must mean something about me. So we want to really engage with those thoughts and face the thought, whether that's, getting creative and sort of drawing what that looks like, or saying it out loud, or recording yourself saying it and watching it. With just right symptoms, we might think about trying to challenge just that feeling of being just right or being even, doing things in different or kind of wrong ways. Does exposure differ by type of OCD? The answer is no. The principles are the same across themes, and no two patients are the same. So you're probably not going to be doing the same exposures with everybody. We want to really understand, what is the feared outcome or the belief, and target our exposures around that. A couple things I just wanted to highlight here is exposures take some prep. So there may be like physical prep that you need. You may even need to do some, work within your organization. Can I leave the therapy space, or what can I accomplish if I'm not able to leave the therapy space? Um, I often work with families on setting a specific goal for what they want to accomplish in the future. And then how can we use exposures to kind of roadmap and get there eventually. So, for example, I had a really severe patient a couple years ago who was basically stuck in her bedroom. She would get caught in rituals if she tried to leave. And so she just decided, I'm going to stay in my bedroom for a very long time. And that bedroom, started to present this really traumatic stimulus for her. And our ultimate goal was to have her back sleeping in the bedroom. But we needed a whole bunch of exposures to get us there, including spending time in that bedroom for short amounts of time, maybe laying in the bed and playing video games, but not sleeping. We really had to work up towards that goal that felt really not accomplishable when we started. We want to prepare the patient for what they're doing. We want to make sure that the situation is anxiety provoking enough that it's going to be helpful and it's not just sort of too easy or not even on their fear hierarchy. We want to take ratings as we go, like I was saying, and pay attention to their behavior and whether things might be too much. Not ideal to stop an exposure in the middle, but maybe there's a way to kind of change it so they still feel like they're conquering what we set out to do but not avoiding completely. And then this habituation point is really important. So we used to believe that exposure therapy was all about doing the same exposure or being exposed to a stimulus enough that someone's distress ratings or someone's fears about that stimulus kind of went down or went away. And we saw that that just wasn't the case for lots of patients, even if they were able to be successful and finish an exposure. And so newer models about inhibitory learning have really showed us that it's the experience of being in an exposure or practice and being able to tolerate the distress in that situation that's much more important than necessarily someone showing that they're habituating or that it's getting so much easier. Um, and the idea is that we're really kind of competing with someone's fear memory about whatever the stimulus is by creating new memories instead that are going to kind of compete with that fear memory. So just because someone is still reporting high anxiety ratings doesn't mean that the exposure has not been successful. I think I've given some examples of exposures already, but just so you kind of can think through, based on different themes, like what might some of these things look like. And I call designing exposures an art because we really are able to iterate and change a lot of variables about an exposure to make them more difficult or a little bit easier. So, maybe there are different levels of things feeling dirty for someone who's worried about contamination. And we might be able to find different objects that feel easier or harder, less dirty or more dirty. Maybe it's something about how long they're washing their hands, and we can think about cutting that down over time. Um, Maybe it's, yeah, the amount of time we're being exposed to something or setting a limit on certain things like checking behaviors. Um, Maybe there's a little bit of a hierarchy around, well, 6 is the worst number that I could imagine. 3 is kind of bad, but 2 is okay, or something like that. So maybe we can think about doing things in intervals that feel, again, a little bit more manageable or not. What exposure does is it violates a person's expectations or expectancies about what is going to happen in a situation. So we give our brain, again, new information about what we're worried about happening, not happening, or that we're able to tolerate it, even if maybe something does go wrong. We help reduce avoidance, which is obviously super, super important if there are very necessary situations that someone has been avoiding. We do often extinguish fears, or people feel a lot less fearful about certain situations. And then we increase someone's ability to tolerate distress and uncertainty in general, which can be super helpful even outside of OCD. Obviously, that's just a life skill. And we increase people's self-efficacy as well. What if someone either can't or won't do exposures? Um, Sometimes we think about slightly less direct ways of engaging in exposure. So I'll do sort of creative exercises that kind of get at the principle, but might not be focused on a person's specific symptoms. So one of my favorite ones is, okay, if you are having intrusive thoughts that you feel like actually change your desires, why don't we have you think about your least favorite food over and over and over and over again? And if your mom serves that tonight for dinner, are you going to feel differently about that food? And they're usually able to say, no, I'm still going to hate it. And that might be a good way to sort of break in a little bit to this idea of magical thinking of, just having those thoughts does not change your identity or your desires. Sometimes we'll use cognitive skills if someone, has thoughts about the treatment or about not getting better or about doing exposures. We might need some, sort of cognitive challenging early on. Motivational interviewing can certainly be helpful and important. I use rewards copiously with little ones for sure who are engaging in really hard work and facing their fears. Um, Addressing comorbidity is certainly important. So I think there are things that we can do if someone kind of hits a stopping point or wants to engage in the treatment, but it's really feeling too hard. Other skills that I think are important to, think about in this type of therapy, cognitive restructuring. I use it a little bit less with kids, and I don't use it directly on obsessions. It's often not that helpful to try to logic someone out of certain obsessions. But again, it might be used kind of around the treatment process or maybe other anxious fears that someone has could be kind of a helpful adjacent skill. Um, Usually during an exposure, we are not necessarily giving someone like a relaxation exercise. We kind of want them to sit with that distress. And I don't want them to learn that in order to get through this tough experience, I always need to be doing something. I think parents often are looking for that and don't like the answer when I say, "Mm, we kind of just want them to work on tolerating this." But I do think relaxation can be helpful, if OCD symptoms are just causing a lot of stress and anxiety, or we might need it kind of outside of the time of exposures. Mindfulness can be really helpful, particularly around for someone who's very fused to their thoughts, in terms of helping us step back and kind of taking some of the weight off of the thoughts, um, and distress tolerance as well. Let's see. I often bring in cognitive diffusion strategies from ACT, which again is all about sort of giving thoughts less power over us, or feeling less fused to our thoughts. And so it's often helpful when someone kind of identifies some sort of analogy or way that they can kind of externalize some of their thoughts onto something else, a sushi conveyor belt or leaves on a stream, and watch those thoughts kind of float by or go by. And again, not sort of engage with them or feel like I have to act on them immediately. Family accommodation is incredibly common in OCD, really all anxiety disorders, but certainly in OCD. And there's a relatively new intervention out of the Yale Child Study Center called SPACE, Supportive Parenting for Anxious Childhood Emotions. And it focuses solely on work with parents to help them reduce accommodation in order to improve child anxiety. So you don't actually even need to see the child for this. Um, and we help parents kind of identify specific targets. And they sometimes even have a little bit of a hierarchy, like an exposure hierarchy for reducing accommodation. But it's a really great intervention. And even if I'm not doing kind of a full space intervention with someone, I'm certainly talking about the role of accommodation with families and working on ways that we can reduce that in the context of the child's work. Um, we often see a similar kind of cycle playing out with families where instead of maybe a specific compulsion, we might see a request for accommodation or even for a parent to engage in a compulsion. And the parent feels pulled into that cycle, or maybe they give in once and all of a sudden the child's asking for it every single time. Maybe it's, standing outside the bathroom, handing me the towel when I'm showering. We really can see a loss of independence sometimes with kids with severe OCD. And so working with the parents is really crucial. And I also didn't mention that we want them to also encourage exposure practice outside of sessions, and support with rewards and things as well too. Um, yes, we do, lots of work on accommodation, certainly on some relapse prevention. Um, and those are kind of the major things that I want to hit. Noticing that it's 7:21. So I'll just breeze through some ideas about trick and excoriation disorder, which are body focused repetitive behaviors under the OCD umbrella. And then hopefully I'll leave a couple minutes for questions. But under that OCD umbrella are these body focused repetitive behaviors. So we get lots and lots of referrals for treatment of those behaviors as well. And they can actually have pretty significant consequences if they're left untreated. Seen some hair eating, and we get trichobezoars that sometimes do need surgery. We might see really significant skin picking that can lead to skin infections or finger and toenails coming off. So this really can be a pretty big problem. Um, and historically, the treatment was habit reversal training, which is basically the idea of competing with the bad habit, or the behavior that needs changing with some other, behavior or competing response. And that's still a huge part of our treatment for tics and Tourette's. But I think, some of the more modern approaches to body focused repetitive behaviors have expanded that out a little bit more, used some elements of HRT, but there's a little bit more of a comprehensive intervention called COMB that I like to use in my practice. And it's very individualized to a certain patient or to each patient, and really involves helping patients identify the function of their picking or pulling behavior. For example, a kid that their hands just always have to be busy. They're always fidgeting. And sometimes their hands thus kind of find their hair or find different parts of their body. We might think about a different strategy for a kid like that than a kid who has some sensory related picking, pulling, where, maybe they're pulling more if they're super hungry, or maybe it just feels really good and satisfying to pull or pick. We might want to think about different strategies there. Habit reversal training does still have a role in terms of making people more aware of these behaviors, and sometimes challenging them. For example, if it's a little bit more automatic, we might want to build up someone's awareness and help them find more adaptive ways to kind of cope with or block those behaviors. But we don't focus just on the habit reversal training in the same way we might have in the past. Okay, I think I'm going to pause. I've got a couple treatment resources. These are some books that I mentioned or that I think, are helpful to recommend to families or to use in your own work, some good treatment manuals. I know we got some questions already, but happy to answer live questions as well. And sorry, that was such a whirlwind.
Thank you so much. That was phenomenal. We can probably even exit out of the screen sharing and then go back into the group mode. There we go. So we do have a handful of questions that came to us, but since we have multiple people here, I'll open it up for a discussion and see if the audience has any questions that they'd like to ask.